Hello and a very good evening to everyone. I am Dr. Varun Agarwal. I am a urologist, uro-oncologist, and a robotic surgeon. Especially, I am trained in management of urinary stones, prostates, any problem related to the urinary tract, and that includes cancers as well. So, I have special training in robotic management of kidney, bladder, prostate cancers as well. So, today, the topic of our discussion would be urinary stone management. Often patients ask me about, Doctor, I drink a lot of water. Why is it that I still get stones? So, what are the causes of various stones that occur in our urinary tract? Now, there can be metabolic causes, lifestyle causes. Some patients have some genetic factors which play a role. Even the drugs, that is, the medicines that they take, they may also cause stones. Apart from that, patients who are more immobile are more at risk of forming stones, along with a sedentary lifestyle who have repeated episodes of dehydration, like those working in the sunlight for a long time. Even those having a metabolic disturbance, they are also at risk of stone formation. And once a stone former, it is said, is always a stone former. So a patient having a history of stones is also at risk of recurrent stone formation. Other risk factors would be a high mineral content in drinking water. Like we know about the hard water that is available in the villages of India. So those patients are actually quite prone to stone formation. And a lot of these patients who are in interiors of India and in the lower cities, they come to us with stone problems. And that is because of the drinking water. Again, dietary intake plays a role, which I will be speaking subsequently in this discussion. Patients having repeated urinary tract infections, like females usually have this problem in and around menses. They are more prone to urinary tract infections. So, they are also more prone to stone formation. Again, patients having long catheters due to some of the other problems, or a neurogenic bladder, which means they may be having some neurological problem due to which their bladder has been infected, and due to that, a lot of patients have stones. So, what are the manifestations? How do these patients present to us? Like the commonest presentation is the patient holding his tummy coming to us and like literally crying in pain that, doctor, I couldn't sleep at night. I was tossing and turning in the bed. So, that's severe abdominal or flank pain. That is the most common symptom. Usually, it is associated with nausea and vomiting as well. Some patients who have the stones in the lower part of the ureter have increased frequency of urination and even pain and burning during urination. And on one odd or a rare patient may present to us with absolutely no urine formation or extremely less urine production. Other clinical manifestations, they may be having hematuria, which means blood in urine. That means they may say that intermittently I pass red clots or intermittently my urine is red in color. Renal colic, which is the same thing. They will be holding their flank and their tummy and they'll be crying in pain. That's a renal colic. Nausea, like I said. Hydronephrosis. Now, what's exactly hydronephrosis? If you see over here in this picture on your right side of the screen, the normal kidney, the central part over here, this is the normal collecting system where urine is formed and it goes down here to this ureter. On the right side of the picture, you see this part is quite, it's swollen up. So this is because this is called hydronephrosis, that means swelling in your kidneys. What are the various diagnostic tests that can be done to know if you have a stone or an infection? First and most commonly, urine analysis. These are the various things that are used in the urine analysis kit. So this is not for you. This is for a doctor. Um, Basically, you come down on a urine analysis by seeing the pus cells. That shows that the patient has an infection, and a patient having a stone would have plenty of RBCs as well, because the stone leads to a small amount of bleeding in the urinary tract, and that comes on this urine analysis as RBCs. A urine culture would help us know which organism, like which bacteria is affecting the urinary tract that is leading to the infection and fever. It also helps us in knowing the antibiotic which is used, which can be used and which is effective against this microorganism. So urine culture is quite a handy and important investigation. Cystoscopy, frankly, it's not really used now to diagnose stones or UTI. This is of the olden times. This, as of now, is a last investigation which may or may not be used, frankly. Even then, it's not used to diagnose any stone. Yes, for treating bladder stones, definitely cystoscopy is needed. So in this, what we do is we take a scope, that is a camera in layman's terms, from the urinary passage of the patient into the bladder and we see the stones. and we try to clear it up. IVP again. Now IVP is basically you undergo an X-ray before which a dye is injected in your arm in the veins. So the kidney, like you can see in this picture here, it gets highlighted by the dye. So this IVP is now being replaced by CT IVP. That means IVP is done along with a CT scan. So that gives a very good picture of the stone. Where exactly is it? Which part of kidney and how big is the stone and what can be the treatment of it? Ultrasound is usually the first imaging investigation. Any patient coming in pain, the first thing any doctor would do is subject him to an ultrasound. It gives us a very good picture again of the stone, its size, location, and everything about it, and the number of stones as well. Other diagnostic studies, retrograde pyelogram, 24-hour urine specimen, and lab investigations are done. CT scan, I would say, is the commonest investigation, the best investigation. A plain CT scan for stones. So basically, we do a non-contrast CT scan without injecting any dye for stones. That is the best thing that is done nowadays. Now, what are the various types of stones? I would like to tell you. Many patients tell us that after the surgery, they tell me that I want to send a stone for analysis. Like I want to see what kind of stone is it. So in the next few slides, just concentrate on the left-sided column. It gives us the type of stones. There are 3-4 types of stones which I'll be speaking about the various predisposing factors and what you can do to prevent them. So first is calcium oxalate stone. This is the commonest stone that occurs. Almost every patient who comes to me has this. 35 to 40% is mentioned, but frankly, I feel from my practice it's much more than that. They're usually small and they get trapped in the ureter, and patient comes to us in pain. Now, the predisposing factors are they have a family history, or they may have a hypercalciuria. That means they are excreting more calcium in their urine, or a hyperoxaluria, or and it's actually independent of your urinary pH. How do you treat it? Again, you have to have a good hydration, reduce dietary oxalate, give thiazide diuretics, cellulose. We can chelate the calcium and prevent GI absorption. And this potassium citrate, the syrup that comes, it alkalizes the urine. This cholestyramine, it binds the oxalates and it helps in prevention of the stone. This calcium lactate as well, it precipitates again the oxalate, the GI. The second type of stone is the calcium phosphate. It's the second commonest stone. 8 to 10% patients present with it. They're mixed stones again, and they are mainly formed in alkaline urine. Now, patients having a hyperthyroidism and hyperparathyroidism, they're actually quite prone to this. So these patients usually have calcium phosphate stones. Again, in the initial part of my discussion, I had said there are often metabolic illnesses which lead to stones. So this is one of them. So treatment is again treating the underlying cause. Struvite stones. So this is again a very common stone. That is because the most common causative thing for this stone is urinary tract infection. And urinary tract infections are quite common, and especially in women. That is why in women these stones are quite common. So the treatment is again antibiotics that can be given to treat infection, and acetohydromic acid is there. There are different surgical interventions because these stones are usually large in size, so they have to be subjected to some surgical intervention. Uric acid stones. Now, again, they are common in people having gout, basically high levels of uric acid in their blood. So Jewish men are quite common to have these, are known to have this, sorry, and they are again inherited. Gout can be inherited as well. So these patients have some underlying genetic disorder as well. So how do we treat them? Urinary concentration of uric acid has to be removed. The urinary concentration of uric acid has to be less in this case. So we give medicines like allopurinol, and we alkalinize urine, potassium citrate. Cysteine stones, they are usually transparent stones. That means on X-ray, a doctor may miss them because they are not visible on the X-ray. About 1 to 2 patients may have these stones, and again, they are genetic, autosomal recessive, inheritance, and they're mainly because of defective absorption of cysteine from our GIT. So that is because of some genetic disorder again. Predisposing factors are acidic urine. So you treat them by increasing the hydration. Alpha penicillamine is a drug, and tripronil again, it helps in prevention of these stones and their treatment as well. A brief discussion on their management. I have divided the management in 3 parts. The proximal ureter, that means the upper part of the ureter. Usually we do DJ stenting or ESWL. or a ureteroscopy in which there is no incision on our body, we just go from a urinary passage and we break the stones, or a percutaneous nephrolithotomy. A separate discussion would frankly be needed to explain each and every procedure in this case. A mid-ureteric stone again can be treated by retrograde ureteroscopy. Yes, an open ureterotomy, that is, it's a discarded and ancient procedure, open surgery, wherein there is a big incision on your tummy. Instead of that, that has been substituted now by laparoscopy ureterotomy, and now, in fact, even by robotic ureterotomy. In distal and the lowermost part of ureter, we do a DJ stenting or a surgery, or you can also do ureteroscopy. So what are the dietary interventions that can be done for reducing stone formation? There are, like, after every stone surgery, before the patient goes back home, this question is always asked to us: what do I do, doctor, to reduce stones? So the next few slides will be on that. The evidence of whatever I'm going to speak now is a bit limited. There is a lot of study which is going on this, but frankly, very few things are you can pinpoint very few things which can actually be said to have been causing stones. So the first thing is increased fluid intake. It is a proven thing. More than 2 liters per day, it does help in reduction of stone formation. You must reduce soft drink intake, particularly which are acidified solely by phosphoric acid but not by citric acid. So I know that we should have a low protein, low sodium, and decreased oxalate diet with increased water and normal calcium diet, when compared to a low calcium diet. So, patients should have a tailored diet based on the metabolic evaluation when compared to an empiric diet. So tailored diet means this only: a low protein, low sodium, and decreased oxalate. Patient is usually subjected to a number of investigations, and on the basis of his reports, we usually plan a tailored diet. Now, high fiber, reduced animal protein diets, with increased oligo-mineral water intake as isolated interventions, they do not have a statistically significant effect on stone recurrence. So it is said that if you have high fiber, you'll have less stones. I don't think that is right, because again, the evidence is really lacking in this case. You can see the strength of evidence in this case is quite low. What are the pharmacological interventions that can be done? Now, there are medicines called as thiazide diuretics. For a layman, I would explain by saying, some blood pressure medications have these thiazides in them. Not all of them, some of them. So thiazide diuretics, they reduce the risk of calcium stone recurrence, in fact, by about 29%. Similarly, hydrochlorothiazide, chlorothalidone, indapamide can reduce the risk of stone formations, but no trial, frankly, has directly compared them to each other. So they do reduce the risk, but how much and as compared to each other, how much, no one knows really. There's no study which has been done properly on it. Other pharmacological interventions would include citrate. It reduces the risk of calcium stone formation by 41%. That's how much it helps. So we usually give a syrup which has citrate in it and helps in reduction of stone formation. Again, allopurinol, it reduces the risk of calcium stone recurrence with elevated blood and urine uric acid levels. So the patient should have elevated uric acid levels. Only then will allopurinol help in those cases. What about other treatments? Treatment with magnesium, frankly, does not reduce the risk when compared to placebo. The strength of evidence is low in this case. And I would like to speak about acetohydromic acid. It's quite spoken about in our field. The evidence about this in patients with chronic urinary infections and struvite stones is insufficient to permit any conclusions. So, however, this also does not exclude the possibility that a drug does not work. So, it's a very gray area, frankly. As doctors, we prescribe it. Because like I said, there is a lot of study which is going on. There are a lot of gray areas in this field. And there is no one pin, there's no one particular thing that if you do this, the stone will not occur, that stone will not occur. There's nothing like that. So we have to try everything as of now till the evidence is still lacking. Now, evidence is based on a number of studies, and a lot of people are doing that. So as of now, we have limited evidence, and hence we still continue to prescribe acetohydromic acid. So how would I like to conclude? Now, whatever I've spoken about in this discussion, in this PPT, I would like to conclude by saying that although the body of evidence is low, however, I would still say that fluid intake of more than 2 liters does help in preventing stone recurrence. Abstaining from soft drinks or eliminating soft drinks acidified solely with phosphoric acid but not citric acid. It reduces the stone formation. A normal calcium, low sodium and low animal protein diet helps in reduction of stone formation. High fiber and reduced animal protein diets may not help in stone prevention. So the effectiveness of other dietary interventions is also not clear. Among pharmacological investigations, yes, thiazide diuretics, citrate, and allopurinol, each combined with increased fluid, they reduce the risk of calcium stone occurrence. Allopurinol it helps when there are elevated blood and urine levels of uric acid. Thiazides or citrates may be preferred initial therapy over allopurinol in patients with calcium stones and no hyperuricemia and hyperuricemia. Patients receiving pharmacological interventions may experience adverse effects, and that may lead to withdrawal of treatment as well. So these pharmacological treatments, although they help you, but they may also carry a load of side effects with them. So we have to be very careful in prescribing them, and the patients also have to be careful and should not take an overdose of these medications. A review of the RCTs, that is randomized controlled trials, they reveal a number of gaps in our knowledge, unfortunately. And what are these gaps? There's no direct evidence whether diets that increase calcium or lower sodium or oxalate of urine reduce the risk. So there is no evidence as such. Again, it is unknown whether the efficacy of dietary interventions differs as a function of participant characteristics. So what do we discuss with the patients and caregivers? That kidney stones have a high chance of recurring if not managed properly. There is a great deal of importance of consuming a lot of fluid, more than 2 liters. If you realize, throughout my PPT, I have been speaking about increased fluid intake. So that is actually the most important, of paramount importance for prevention of stone formation, because we live, especially in the country like India, where the weather is really, can be hostile at times. Water intake should really be adequate. There are benefits as well as adverse effects of medicines in preventing kidney stone recurrence. And some dietary changes may be beneficial in preventing kidney stone, like eliminating soft drinks acidified by phosphoric acid, increasing calcium diets, and limiting oxalate containing foods. Thank you so much for your patient listening. I'm taking any questions. Thank you.
Thank you, sir. Thank you so much for your wonderful presentation. Sir, there are some questions in the chat box.
Right. Yeah. Could you say the questions?
Sure, sir. Till what size stone treated without surgery?
So stones basically, it's said around 5 mm, 6 mm. We can treat them by just medicines and having a lot of water. However, frankly, I'll tell you, sometimes even a 6 mm stone may get stuck. It may not pass off. Sometimes an 8 mm stone may also just pass off. Chances are less of an 8 mm stone passing off, but then it depends on your ureter, how much your ureter can hold. So I can't really say, but on an average, 5 mm up till 5 mm, 6 mm, I would still go with conservative management. I will try and avoid surgery. Even 7 mm to some extent, I will avoid if the patient is not having too much of pain. But yeah, above that, it is better to undergo a treatment because it eventually has an effect on your body.
Thank you, sir. So the next question is, what food we should avoid for preservation of stone?
Like I said, we must have an adequate amount of calcium diet, not low, not high, because even low calcium and high calcium, both of them really affect stone formation. And soft drinks you must avoid as much as possible. Have lots of water. Fiber diet does not really. There's very less evidence that fiber diet might help. So having good amount of fruits, vegetables, low oxalate diet would also help. Next.
The next question is, what causes kidney stone formation?
So, firstly, the exact cause is actually not known. I can say multiple risk factors that can lead to stone formation. There are multiple risk factors like having very less water, dehydration, patients having some genetic problems. Patients are more prone to stone formation. Some patients are just genetically, they are more prone. So those patients have, and patient having a past history of stone formation is again predisposed to having them in future again. So these are the basic things, and there is no one pinpoint cause that I can point out that that is the cause of stone formation. Frankly, there are multiple small things. The best thing is you can prevent them by just having a lot of water.
Thank you, sir. The next question is, what are the symptoms of kidney stone and how can I prevent future stones?
So symptoms, if you see, I mentioned that patient presents to us in severe pain, and he holds his tummy, and he's usually uh, previous day he's been crying in pain usually and having nausea and vomiting. So this is the commonest symptom of stone, but if the stone is in the ureter, usually these symptoms arise. A patient having a kidney stone usually is silent, low, dull, aching pain. We have that. Should not be very severe. You may just think that this is just another muscle ache. I may have worked out too much in the gym. But a ureteric stone will give a lot of pain to the patient, and sometimes he may have blood in his urine as well.
Thank you, sir. That was the last question of the chat. Can we wait another 1 to 2 minutes if any question comes?
Sure, no problem.
Okay, thank you, sir. Sir, there is one question. How are kidney stones treated?
So there can be surgical management, or there can be even a non-surgical management. First, we try to uh, postpone surgery as much as possible. We admit the patient, give painkillers. Sometimes stones pass off. There is no medication which will melt the stone. Frankly, so I want to make it very clear. Usually, what everyone says, there are a few people who say that we'll give you medications to melt the stone, but there is no medication like that. Yes, there can be medications which may cause increased urine production, which will flush off the stones, but there is actually nothing which will melt it. So, it is better that if there is a stone pain, you take it seriously, you go to a doctor, you get admitted for the pain. Yes, he will give you painkillers, he'll try to relieve you as much as possible, but 1 or 2 days or 3 days of trying to avoid the surgery is fine. But still, if you are in pain, then the next step is a surgical management. Now, when you speak about surgery, it depends on where the stone is. Frankly, you know, if it's in the bladder, we can do a cystoscopy. And after doing a cystoscopy, we remove the stone. That means we take a camera into a urinary tract and we break it with the help of a scope. So that is one method. There will be no incision on your body. So that is a bladder stone. Similarly, ureteric stones are also done that way. We take a scope, a camera through a urinary tract into a ureter, and we break the stones with the help of a laser and we bring it out. Again, there's no incision on your body. If it's a kidney stone, it's a large stone. It's a surgery called as PCNL, wherein I think you a PCNL where we make a small 1 centimeter incision on your back and again we put the place. So yeah, that's how stones are treated. Non-surgical treatment would be ESWL, wherein you're made to lie down on a machine, and it's just like it's a machine like CT scan. You just lie down there, and you'll hear voices, thuk thuk, and the stone usually breaks off. So the stone clearance rate in that case may not be that good. So yeah, that is a problem. Otherwise, surgery almost 95% stone clearance rate is there.
Thank you, sir. So it was a wonderful session with you. It is our pleasure to have you with us today on this topic. So with the permission, shall we conclude this meeting?
Yeah. Thank you so much. It was really good
Thank,
answering the questions. I hope if there's anything, you can email me, call me, message me directly, and ask me any questions.
uh,
Yeah.
thank you, sir. Thank you, sir.
Thank
So
you so much.
on this the behalf of organizer, I would like to thank you for your informative and educative talk, sir. Thank you so much for your valuable time.
Thank
So
you.
from here now, I'm ending this meeting.